Hello, my name is Dr. Sahar Abdelmoanim, and I am presenting our case titled, When a Simple Food Bolus Isn't Simple. Distal Esophageal Spasm and Hiatal Hernia in a Nonagenarian. This work was completed in collaboration with my colleagues from AMN Healthcare, Nova Southeastern University, and the Internal Medicine Program at Larkin Community Hospital. Sliding hiatal hernias are very common in patients with gastroesophageal reflux disease, present in up to 50 to 94% of cases. While GERD is the usual concern, hiatal hernias can sometimes present with mechanical complications, such as esophageal food impaction, particularly when associated with distal esophageal spasm. Video fluoroscopic swallow studies are often the best modality to evaluate swallowing dynamics and esophageal motility in these patients. We present a 95-year-old woman with dementia who came to the emergency department with a sensation of a foreign body and discomfort in her esophagus. Her initial vitals were stable, with a blood pressure of 110/68, heart rate of 62, respiratory rate of 20, and oxygen saturation of 100% on room air. On exam, she was alert but oriented only to self. There were no oral abnormalities or drooling. Her abdominal exam showed hypoactive bowel sounds without tenderness. Labs were unremarkable. Imaging revealed both a small Spigelian hernia and a small sliding hiatal hernia. CT of the chest showed esophageal distension with likely food residue. CT of the neck confirmed a significant amount of food material within the esophagus, consistent with slow transit. She was admitted for suspected food impaction and given ondansetron as needed for nausea. A follow-up barium swallow demonstrated a distal esophageal spasm. The diagnosis was esophageal food impaction due to a hiatal hernia complicated by distal esophageal spasm. Despite her age, the patient remained hemodynamically stable. She was transferred to the ICU for close monitoring and aspiration precautions. Gastroenterology was consulted, and an endoscopy was performed without complications. This case highlights the clinical importance of recognizing the coexistence of hiatal hernia and distal esophageal spasm. Management typically includes GERD therapy for hiatal hernia, but medical therapy for distal esophageal spasm often provides only partial symptomatic relief. When food impaction occurs, endoscopic intervention is frequently required, as in our patient. Figure 1 demonstrates CT imaging of the hiatal hernia and retained food in the esophagus. Figure 2 shows the barium swallow revealing a dilated, tortuous esophagus consistent with distal spasm. Figure 3 shows endoscopic images confirming the food impaction. In conclusion, this case emphasizes the need for careful evaluation of dysphagia and impaction in elderly patients, where hiatal hernia and esophageal motility disorders can coexist. I'd like to thank the staff and faculty of Larkin Community Hospital for their support. Thank you very much for listening.